Hello, this is Fernando J. Martinez. I am the Chief of Pulmonary and Critical Care Medicine at Weill Cornell Medicine in New York City. Welcome to this educational activity on IPF and other ILDs, focusing on updates from our recent annual meeting of the American Thoracic Society, which just held in San Diego in late May of 2018. It was a very busy meeting. There was a lot of stuff, and so in 20-25 minutes, I can't show you the entire meeting. And I'm not going to show you what I think are the absolute best abstracts that were presented. But I'm going to try to give you a sense of where I think the field is going and where some of the presentations were highlighting. So that's what I want you to pay attention to. After you complete this activity, you can access the post-test and evaluation form by clicking the red credit button. I encourage you to download slides, practice aids, and any other activity features that may interest you because there is a lot of information.
The following audio is part of a certified educational activity titled Evaluating New Advances in Idiopathic Pulmonary Fibrosis and Other Interstitial Lung Diseases. Updates from San Diego. Access the entire activity and complete the post-test at www.peerview.com/FBJ. Downloadable slides and practice aids are also available.
We'll start off with one very hot topic. There is an ATS, ERS, ALAT, JRS, multi-investigator, multi-specialty group that has been revising IPF guidelines. The discussion at this particular ATS meeting reflects the update of the diagnostic components. And this follows, in part, what the Fleischner Society recently published, which was a revision of the imaging criteria for the diagnosis of usual interstitial pneumonia, or UIP, further refining what we currently consider to be the typical UIP pattern. That hasn't changed. That remains very clear. And then some of the changes that the Fleischner group recommended were the probable UIP category and an indeterminate category. And this is in part based on clinical trials data from some of the newer antifibrotic agents. Biomarkers were studied by multiple groups in data presented at the ATS with multiple different goals, many of which were diagnostic. We'll talk about that in a second. And a fair number of those were such as the abstract that I'm showing you. This, again, just one of many, which was a really cool mechanistic examination of plasma, so circulating biomarkers, easier to collect, from just a relatively small number of individuals with well-defined IPF who were receiving an antifibrotic therapy. In this case, it was pirfenidone. And they were compared to control subjects. And the thing that was really cool about this was that they were looking at not only circulating samples, but tissue-based samples using a very complex and state-of-the-art mass spectrometry approach for developing assays for proteins. And what they were trying to look at was, could you look at circulating protein signatures, relate that to lung protein signatures in this relatively small group of individuals? And they were actually able to find thousands of unique proteins, looking at, again, the relationship between what was present in lung, what was present in plasma, how they related to antifibrotic therapy. This is preliminary work, but it is particularly cool because it has the potential not only of diagnostics, it has the potential with a circulating marker panel to address what's likely present in the lung. It may provide practical value for you and I as we manage patients, but probably most importantly, it may provide really interesting views on how to assess pharmacodynamic biomarkers for a new series of antifibrotic agents that are being developed. And so in following that concept, for information that we all need in terms of how to manage our patients, is the idea of how you can use biomarkers to determine therapeutic responsiveness in our patients. So there's an ongoing study that is the INMARK study that has used data from a previous biomarker study called the PROFILE study to try to examine what is the pattern of change in the degradation of extracellular matrix components in patients that are being followed very rigorously, longitudinally at regular time points to determine, is there a change that is occurring in these markers of turnover of extracellular matrix as we use an antifibrotic agent. I think in this case it was really nintedanib. The goal of this particular study is to provide you and I, at an individual patient level, what are the changes in easily measured parameters, circulating components, and how that relates to therapy, therapeutic response clinically, mortality long-term, so that hopefully we'll be able to develop a sense of patient gets treated, this is what happens to a circulating biomarker, this is what happens to them clinically long-term, and we can get a sense of whether there's response or not. This would be crucial from the point of view of how we manage patients. The last little biomarker snippet I'll give you is information regarding other interstitial lung diseases. So there was a lot of movement in this IPF in other ILDs, not just IPF. So this happens to be one, and I like this one because it's one of my junior faculty members in collaboration with a group at the Brigham, who's tried to look at subjects with rheumatoid arthritis with and without interstitial lung disease. And as you know, RA-ILD is a particularly problematic complication of that connective tissue process. So this was a relatively straightforward approach asking the question, can we, by using one of these large proteomic platforms, multiple proteins in blood, can we identify individuals with rheumatoid arthritis who have established ILD, who don't have ILD, or at risk for ILD in comparison to a control group? If you look at large numbers of proteins from a blood proteomic panel, you actually can start to see that there are protein combinations that identify not only fibrotic rheumatoid arthritis ILD versus pulmonary fibrosis, but probably most importantly within this context is individuals with rheumatoid arthritis who have or do not have ILD. These patients will be followed longitudinally. The key here is developing a proteomic panel on blood that can be used to determine rheumatoid arthritis patients with, without ILD, at risk for ILD. This is crucial for the development and the implications for antifibrotic therapy in these patients. So, lots of movement around the idea of biomarkers from pharmacodynamic to diagnostic to therapeutics at this ATS. Over the course of the next 1 to 2 years, you mark my words, you're going to see a lot of motion in the biomarker world that'll be clinically relevant to how we manage our patients. There was, as you could expect, a lot of movement at the ATS with regards to antifibrotic therapies. That is, those that are currently approved, we got 2 of them, and those that are being studied. So let's talk briefly about some of the information that was presented with the approved drugs. No huge, large studies released at this particular meeting in that respect, but there were a whole series of very interesting analyses of the previous trials and real-world experience to try to give us a sense of how these drugs are likely going to be beneficial for our patients, in this case with IPF. So what you see on the screen is a pooled analysis from the available trials with nintedanib. And the question was a pretty straightforward question. It was clearly a question of, could you get a sense when you pool all these studies that use relatively similar inclusion criteria, whether there was a mortality benefit from this particular agent? The studies were not mortality studies, so when you pool them all together, you get a higher statistical power. And the analysis suggested that there actually, with that particular agent, may be 27% relative reduction in the risk of death. So again, these are not prospective mortality data, but they were data collected in very rigorously performed clinical trials. And it gives you a sense that, in contrast to a few years ago, the IPF therapeutic field is totally different now. And in fact, it may well be that there is a mortality benefit. In this case, that happened to be data with nintedanib. Similar approach were taken by other investigators, pooling data from all of these large trials to try to get a sense of how tolerable are these drugs, and are there components of the management of these patients that will help us in achieving the optimal tolerability for these individuals? Reminding you that in all these trials, there was the potential of having a dose reduction and escalation to manage adverse events. As you would imagine, the data suggested what many of you see clinically, and that is gastrointestinal side effects are the most common with, in this case, nintedanib. But there was also a strong sense that if you were able to appropriately manage dosing, including the use of the dose de-escalation and re-escalation, you actually had a pretty reasonable tolerability profile. There were other data presented that were more real-world components suggesting that what individual clinicians and patients are seeing in practice isn't dramatically different than what these clinical trials suggested. There were similar data presented with their pirfenidone data sets. So this happens to be a pooled analysis of multiple pivotal studies of pirfenidone. Some of this has been published in the Blue Journal within the last year and a half. But this is sort of an interesting wrinkle that Brett Lay took to this, which was asking the question, there's already a sense that pirfenidone has a beneficial effect on respiratory hospitalizations. Is this seasonally related? And as you see in the figure, as you examine the spring, summer, fall, and winter seasons, you see there is in fact a seasonal variation. In respiratory hospitalizations in IPF patients, all of us have seen this clinically. There's proof that it actually does happen. And in fact, pirfenidone seemed to attenuate those across all the seasons. So again, data from published trials, but interesting sub-analyses that are clinically relevant because this is kind of stuff we see clinically. So in this particular case, a group of investigators looked at prospectively patients that were diagnosed with IPF, multiple centers across Argentina, and then following patients longitudinally after the institution, in this case of pirfenidone therapy, to see what happened in these patients over time. The data presented were in relatively small numbers, but it was very interesting because if you take care of patients, you've seen some of this clinically. There are clearly patients who, despite an antifibrotic, in this case pirfenidone, continue to progress. There are others that clearly progress more slowly, and what they were trying to do was contrast those patients during regular time courses to define what occurs clinically in the real world. And my sense is that the antifibrotics, in this case pirfenidone, does attenuate the loss of lung function. It doesn't completely abate it, and there are some patients who continue to have more rapid progression. That's why I'll show you in a second all of the new therapeutic components that are being now considered. So there are, as a result, emerging concepts for how we're going to treat our patients with IPF and other ILDs. Clearly, the antifibrotic agents we currently have work. There is no doubt about it. They have benefits on multiple parameters that are relevant to our patients and to you as clinicians. But as that last study just showed, there's still a significant room for opportunity to be able to enhance our therapeutic approach. So let's think about how you could potentially tackle this. So there were a whole series of studies that addressed therapeutic approaches to our patients with IPF and other ILDs, but we're going to focus mostly on the IPF, and that includes studies with our currently available compounds. We're going to become, in the IPF world in particular, much more like our oncology colleagues, where we're mixing therapeutic approaches, ideally in the future targeted specifically to the patient and their biological needs. But this is an example of that approach. So there have been a couple of studies done by the manufacturers of these particular antifibrotic agents, and this was the Injourney study. So this has been published recently, and this is sort of a sub-analysis of that, but it's interesting clinical information. Patients were either treatment naive, started on nintedanib, and then placebo or pirfenidone added, and there were patients who came into this particular study on nintedanib, and then placebo or pirfenidone was added. So they were asking, was there a difference in the tolerability profile in those two types of patients? Individuals that had been treatment naive, had been on nothing when the nintedanib was added, and then pirfenidone was added, tended to have a higher adverse event profile than people that had already been on nintedanib when they came in. Both of those groups had a higher level of GI adverse events when you combine them. Again, not surprising since these drugs have tolerability, GI effects, and they're a little bit more prominent when you combine them. This was really a safety study. This was not an efficacy study, but it does show you that in the future there may be the opportunity of combining even the currently available antifibrotic agents. This is going to require larger, long-term, multi-center studies with efficacy as a primary endpoint, but there was a fair amount of discussion at this meeting regarding how the current drugs could be combined, if at all. Now, probably to me, from a therapeutic perspective, the most exciting components are the next few slides because they are new therapeutic trials that are really providing some tremendous insights. So this one I'm biased. I'm a co-investigator in this particular study. This was the RAP IPF that Ganesh Raghu presented. This was an NIH-sponsored trial of laparoscopic anti-reflux surgery in patients with IPF and confirmed reflux across 6 centers across the U.S. In this particular study, 58 subjects underwent surgery or no surgery. So this is as aggressive an intervention as you can get for reflux. And the primary endpoint was the change in forced vital capacity over time with a series of secondary endpoints that were predefined. If you look at this, it was not statistically significant, so we'll grant you that it did not meet the primary endpoint. But this was likely a result of statistical power because if you look at those curves, they really do seem like they're separating. And numerically, there were very interesting trends for major events like deaths that favored reflux surgery. Reflux really does have an impact on at least progression of IPF, and further study is required regarding anti-acid therapies because these data are really, really very intriguing. So then there were a whole series of studies of pharmacotherapeutic approaches. And so I'm going to show you just a series of these in sequence. So the first is this particular study that was actually published simultaneous to the presentation by Ganesh at the ATS. This was a multinational, large phase 2 study that was examining the safety of a drug called PRM151, which is a human pentraxin 2. Actually, it's a protein that's important in modulating macrophage function and its antifibrotic effect. It's been tested in myelofibrosis, and this is now an application in the lung. So this was not a huge study, but it was a well-designed 24-week study, drug, placebo-controlled, patients with clear diagnosis, and you see the criteria. That's pretty standard criteria. It's 28-week FVC predicted with a series of secondary endpoints administered or monitored. And some of the results are here. Even within this relatively short period of time, in a relatively small study, there was a significant difference between patients treated with this pentraxin 2 versus placebo. There was a greater effect in patients who had not been receiving concomitant antifibrotic therapy. But I would also argue that even in people who were on antifibrotic therapy, there seemed to be a beneficial effect to the drug. And one of the first times we've actually seen this in an IPF trial in a well-done, very rigorous 6-minute walk study. 6-minute walk seemed to improve, favoring this particular agent. So here's an example of a new pathway being targeted with a relatively small phase 2 study showing really very intriguing results. So think about the evolution of therapy in our IPF patients. We went from having nothing to now having 2 confirmed beneficial antifibrotic agents, another one about to be launched in that area. Another study that was published simultaneous to the ATS was this particular compound, which is an autotaxin inhibitor, another small molecule. Relatively small study, very detailed in terms of its pharmacokinetic effect. This particular enzyme is the main enzyme that's responsible for LPA, lipophosphatidylate acid production in blood, and that particular pathway has been implicated in patient studies as being related to patient progression. It's been suggested to be an important pro-fibrotic pathway. So this relatively small study, which was a controlled trial, examined the clinical implications and potentially some of the biomarker components that were anticipated. And the overall adverse events really didn't seem to be dramatically different between one or the other. There was a little bit of an imbalance in terms of infections, but again, a small study, and this is going to require further confirmation. It's the next slide, and this is in Lancet Respiratory Medicine, that I think was the most intriguing to all of us. There seemed to be not only a reasonable safety profile in these well-defined IPF patients, seemed to be a physiological effect favoring the agent. So you now had a second different pathway that clearly seems relevant to fibrosis in our patients with IPF, where you now have a strong suggestion of a beneficial effect to this particular compound. This company has already announced 2 large multinational phase 3 studies to test this drug in IPF patients. So now we have 2 more drugs that seem to have a beneficial effect. This was a study that was a phase 2A randomized placebo-controlled dose escalating study. Part of the reason I like this study so much was that it was incredibly rigorous in its format. This was patients that were bronchoscoped on multiple occasions in trying to develop not only the clinical safety of the drug, but evidence that this was targeting the pathway in the lung, this SMAD2 pathway that is felt to be very relevant for profibrotic effects in these patients. So this was a very complex study that really provided insights regarding how targeting this particular pathway in patients using various doses was able to define that, in fact, of the 41 patients that were dosed with either the BG00011 or placebo, there was a dose that seemed to have not only the best safety effects clinically, but also was able to have near maximal inhibition of this particular pathway. And as a result, this company now feels comfortable that they have a sense of what the dose would be in a larger study. So here's another example of another compound, our biologically relevant pathway, that's going to proceed to a larger phase 3 study. Now, it wasn't all positive. I got to give you the other components. So this particular pathway, this was presented also in the same session, was a pathway that I really felt was going to be a approach that was going to be reasonable. This was targeting IL-13. And since this was a very well-designed, large, multinational phase 2b trial of this particular monoclonal antibody targeting that pathway, and unfortunately, despite large number of patients being randomized and followed, there just didn't seem to be any major effect versus placebo. It didn't matter how they were stratified or examined. So I think we've learned 3 good hits, 1 where we missed, at least with this particular pathway. It did seem to be safe, and it certainly was well tolerated, but unfortunately didn't seem to have the effect on lung function decline that I think any of us had hoped. But I'll leave you with a positive note in that respect, and that is another drug, this particular PBI 4050, which already has completed a phase 2 study. Where there was a strong suggestion of efficacy in that study. This was sort of a sub-analysis from that study, same session, where they were looking to see whether there were biomarkers that were plausible biomarkers of an anti-fibrotic effect of this agent, whether they were actually seen. And interestingly enough, there's already been shown some clinical efficacy. That was the previous published paper. But this was now demonstrating that there were, in fact, biomarkers in the active therapy arm that actually seem to be decreasing with therapy. This is also quite relevant because it gives us a sense that we may actually have the potential of being able to assess how a patient is responding. Some of the most interesting results were when this drug was given in combination with nintedanib. And in this particular abstract just presented, it decreased this marker CCL18, which has been now recognized as a really good marker of disease severity in IPF patients. So this drug is also proceeding to a larger phase 3 study, and it has the potential of having a strong biomarker component linked to it. So think about that. In one session at the ATS, we had 4 agents that showed beneficial effects in earlier phase studies, all going to be proceeding to phase 3, and 1 miss. That's a pretty good batting average there. There were a series of other abstracts presented I'm going to just briefly mention, which I think are interesting because they are also combination approaches. And they're based on previous data that the IPF network, an NIH-sponsored multicenter trial, published. So this is one that's called InStage. This is a study of patients with severe IPF. These are individuals with very low DLCOs, much more impaired than in all the other previous studies but one, the STEP trial in IPF-NET, which was a trial of sildenafil. So this is essentially simulating that population. Now with baseline nintedanib therapy, asking the question, does sildenafil added in this severe patient population improve patient-reported outcomes and clinical events? This is unique because this is a population of patients that we all see who have not been previously studied in a systematic fashion. This study will be reading out sometime this year. There was also presented at the meeting a similar study design with pirfenidone. Pirfenidone, sildenafil versus placebo added in patients with severe IPF at high risk of pulmonary hypertension. So both of the current antifibrotically available agents, nintedanib, pirfenidone, learning from an NIH-sponsored IPF, severe IPF study, are now going to be reading out sometime in the next year. It's incredibly cool. I have no idea how these will turn out. Having been involved in that IPF-NET study, I'm hopeful this will work because I think this will be a wonderful combinatorial approach to our patients with more severe disease who have not been systematically studied to date. The ATS, from my view, the key take-home points are that the diagnostic approaches to our ILDs are evolving. The next ATS, ERS, JRS, ALAT guideline is focused on that. That'll include a series of components that I think you'll find very clinically relevant. There's a lot of motion in biomarker work for diagnosis, therapeutic response monitoring. For us, that's going to be important clinically. Pharmacokinetic monitoring, that's important for future therapeutic development. There is a lot of motion in providing insights regarding what our currently available drugs can do for patients, how they're best managed to ensure the maximal tolerability, how we can combine current available drugs together, we'll see in the future, or with other therapeutic approaches, and then multiple therapeutic avenues targeting biologically relevant pathways in our ILD, specifically IPF patients, that are all going to be moving into phase 3 studies in the next year. It is absolutely dramatic how rapidly this field is moving. And for people like me who've been doing this for 30 years, it is just dramatically better how we manage our patients than it was in the past. So, hope you got something out of that discussion today. Hope you found the activity informative and you can apply some of this to your practice. Thanks a lot for participating.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post test for instant credit at www.peerview.com/FBJ. This activity is supported by an independent educational grant from Boehringer Ingelheim Pharmaceuticals Incorporated and an educational grant from Genentech.